Good afternoon or good evening, everybody, and welcome to our MDA Advocacy Institute that is going to recap what has happened within the budget reconciliation effort that passed Congress just about a week and a half ago or so at this point, and look forward to what comes next. I am Paul Melmeyer. I'm Executive Vice President of Public Policy and Advocacy at the Muscular Dystrophy Association, and I will be your moderator for the evening. So let's move forward. Just a couple of points on, again, what we're talking about. We're going to start with housekeeping, just a few reminders, especially perhaps for those who are joining us for the very first time. We'll be talking about the campaign that we ran along trying to prevent some of the most damaging cuts to Medicaid and access to health care potentially as we could. Then we'll talk about the policy spotlight, what was actually in the final bill that passed Congress. We'll go into some amount of detail in what was within the provisions that affect access to Medicaid, access to private insurance, access to Medicare, as well as some other provisions that are we know to be important to those with neuromuscular conditions. From there, we'll talk about the path forward. We'll talk a little bit about how MDA can help as potentially folks are experiencing the effects of this legislation. We'll talk about via public policy what might come next, and the ways we can still all be working together, both in the context of access to care in ways that are implicated by the passage of the legislation, as well as in other areas. In fact, areas that we're working on right now that you can join us. And of course, we'll end with Q&A, but as always, we will be happy to take very pertinent and relevant questions as we're moving along. So let's move to the next slide. And I think it will be there where it will tell you where you can submit those questions. So you see on the bottom right of your screen, you have the three little dots. Click on those little dots and go to the Q&A. At the Q&A, that's where you can submit questions to the panelists on anything we're talking about, anything germane to the conversation. Now, of course, there's also the chat box. It's a great place to be chatting with your fellow attendees, but just to keep things a little bit better organized on our end, if you don't mind trying to use a Q&A box, that's always appreciated. Now, on the bottom left of your screen, you can find the little CC button. That's for closed captioning. If you'd like to opt into closed captioning, just press that button. And then a final note that this is being recorded. So if you're trying to digest as much of what we're saying as possible, first of all, thank you. But second of all, know that you don't have to catch every single word. It is recorded. We'll be posting it onto our advocacy page and MDA's YouTube channel in just a little bit whenever we're able to get it up there. So feel free to catch up on anything you potentially miss in the recording when we get that posted. But know that you can catch up on that a little bit later on. Okay, so let's move on to the next slide where we're going to tell you who's joining you this evening from MDA. Hopefully by now, if you've been joining us in the past, the three of us are familiar. Of course, there's myself, and I'm joined by two directors on the public policy and advocacy team. You'll be hearing from Mark Fisher, our Director of Advocacy Engagement, as well as Shannon Wood, our Director of Disability Policy. And we'll be sharing the mic, if you will, tonight, talking about what was passed in the One Big Beautiful Bill Act. So with that in mind, I think before we actually get to the details of the legislation, we're first going to start with the campaign that we ran together, how we all worked together around this legislation, as I think this is actually what we're most wanting to reflect on as we're looking back at our work over the last 6 to 7 months or so. And with that, I'm going to hand it over to Mark Fisher, who's going to take it away. Mark.
Thanks, Paul. I appreciate it. First, before I begin, we're hearing some things in the chat that folks might have some issues hearing the presentation. So there's some audio settings you can check in WebEx to make sure that you've connected to the audio. Also, I'd recommend that you check the speaker volume. Sometimes when WebEx pops up, it kind of mutes your own speakers by accident on your computer. So that can happen. So just a few things to check. So hopefully most of you can hear us. So with that, we really just wanted to talk a bit about the campaign and what we've accomplished together for almost over 7 months. There's no doubt that folks, including us and many on the call, are a little bit probably disappointed about what passed a couple weeks ago. But what we shouldn't be disappointed about is the amazing work that we all accomplished together. We really, as a community, did amazing work to lift all of our voices and share with members of Congress and the public at large how important Medicaid was. So before we go into legislation, we just wanted to take a moment to reflect and look back at what we've done together and show our gratitude for each and one of you. So with that, we did a lot of amazing things as a community. First, there's no doubt that members of Congress heard from all of us from coast to coast, from every single state in the country, and about how important Medicaid is to us and the community. MD advocates really crushed this. We sent over 13,000 messages to lawmakers from over the country, and that is a record for the MDA Grassroots Network. Our network has never sent in more messages on a single subject ever. This is the most we've ever done as a community. It is a pure record, and we are just grateful for every single one of you who took the time to contact your member of Congress. In addition, as we look into the numbers, it's even more impressive. 41% of these messages contained a personal story or personalized in some manner. And that's really vital. As members of Congress get more and more messages, like we all do in our own inboxes, it's so vital that we put personal messages and personal stories to make sure they reflect us as constituents. So 41% of those messages contain that personal story or something that was customized, which is key. That gets our messages to the top of the pile and ensures that members of Congress, in fact, read our messages the whole way through. So for that, thank you. In addition, we had over 2,400 new people take action with us during this campaign. So we grew the amount of MDA grassroots volunteers as well. So from that point of view, we've set some records and we should be proud that we made sure that members of Congress heard our voices. But we did more than that. Our advocates, and many of you who did this on the call, really shared your stories in a personal way through first-person testimonials. We had many people submit videos. You can see an example there on the bottom right, sharing not only with your member of Congress, but the public at large, why Medicaid is important to you and to your family and to your independence. So for that, we're grateful. We had so many people raise their hand and say, I want to submit a video. I want to share why this is important to me. So we're super appreciative of that. We had many meetings with lawmakers this year as well. Folks traveled to the in-district office. Folks set up digital, virtual meetings. Some folks were in DC, and all in between, meeting with key members of Congress and their staff all throughout the year, up until the final few days. We had advocates do those meetings that were just a couple days before the big vote. So up to the very, very end, folks were still saying, I want to meet with my member of Congress. I want to speak to them. And we're grateful for that. A new thing that we have done here at MDA is really try to utilize the press and papers, and especially those local papers. We had letters to the editors published from coast to coast, from South Dakota to West Virginia to Florida to Virginia and everywhere in between. Another way to share our stories, some people did it via video. We had folks decide to do it via their press and their local papers and share those letters to the editor, which is great. Many of those letters all those letters were sent to lawmakers, and some of those allowed us to get into some key offices at key times, and many of you joined us for those. So those had such immense power, and we're very thankful that you stepped up and decided to team up with us on those. I'll get to this in a second, but we teamed up with many other organizations that MDA works with as well to submit key letters at key times to share with Congress why Medicaid needs to be protected. So we worked as a whole group of folks in the neuromuscular community, both as individual advocates, but as organizations as well, to make sure our voices were heard. And I'll get to that in a second. And finally, we shared our stories far and wide on social media. We did a lot, and we should be really happy with what we've accomplished together. We tried new things together, and we set records together. So because of that, we just wanted to start out with the webinar with that, saying thank you. So just a few more examples. We had the letter that you see on the screen there was the letter from 41 organizations that represent the entire spectrum of the neuromuscular community, whether it's ALS, LGMD, FHD, and anywhere in between, all the other any other organizations between. We really came together as a large community, as you can see by that letter, to make our voices heard. So we're really proud. Many of you who might represent these organizations are on the call with us. So for that, thank you. You might maybe belong to one of these groups. Thank you. We truly tried to work together with all organizations to make our voices heard. Members of Congress heard. On the upper right, upper middle, that is Representative Castor, who read a letter submitted by MDA in the public record about Medicaid. When we submitted these letters, we included many stories that you submitted along with us to make sure that lawmakers truly heard our voices. See in the bottom of the screen, that's Bryce Madsen. He shared his story on social media and YouTube and more in many places. So we used your stories. And then on the far right are some other examples of letters to the editor that we sent. So it is a truly all-encompassing campaign. Every day that we worked on this together, we were in awe of what our MD advocates could accomplish together. We're proud of every single one of you. Again, we're understood that this is not necessarily the result we wanted, but we can have our head held high that we did everything we can. I'm going to have a sports metaphor here. We let everything on the field. We let everything on the table that we possibly could. And we should be happy of all the things we should be happy of the campaign that we ran together. And it's only going to set us up for more success. And it's only going to make us stronger as an advocacy network. So we wanted to start the call with that. We're so grateful for you and everything you've done. And with that, we will turn it over to the policy portion, which I believe Shannon will be taking. So Shannon, we'll turn it to you.
Thanks, Mark. Hi, everybody. Just like Mark said, this was definitely not the policy outcome that we wanted, but thank you for each of your hard advocacy on this bill. It was a really incredible effort, and we did see some of those more dangerous, longer lasting provisions, things like per capita caps, ultimately dropped. So thank you very much. And that said, the changes that we talk about today, they might seem minor, but we know that they're going to have a big impact on states and ultimately on access to care. So let's take a look. Next slide. So starting with like a high-level overview of what was included in the ultimate bill that passed, we have held 2 advocacy institutes on this bill. You may have joined us for those. That being said, that there were several changes made to the bill through the process as it moved from House and Senate and back to House. In the final bill that passed, which ultimately looked closer to the Senate steeper version than that original House version, we saw $1 trillion in cuts to healthcare programs, and we know that this is anticipated to generate 17 million more people uninsured over a decade. This is up from initial estimates of 16 million. We know that there will be longer delays for home and community-based services, higher out-of-pocket costs, onerous paperwork requirements, impacts to rural healthcare, and other barriers to access. So we're going to be walking through each of those. I also want to share some kind of common themes in the bill. One is that major costs has been shifted to states. A lot of states have shoestring budgets, and states will be unprepared to kind of take on these costs themselves. And then we also know that Medicaid expansion states were hit particularly hard. So you see that in this map here. You can see which states have expanded Medicaid. 40 states and DC have expanded Medicaid. So when I talk about expansion states tonight, just know I'm talking about most states when I say that. All right, so if you want to move to the next slide, we're going to go through some of the big provisions in the bill. This is not going to be an exhaustive overview, but kind of a highlight reel, if you will. And we're going to start with state Medicaid financing. So this is how many dollars the state has to provide Medicaid services. So starting up with provider taxes, this is something that changed many times throughout the legislative process. To back up a bit, these are one of the few funding mechanisms available to states to fund their share of the Medicaid program. Again, Medicaid is a joint federal state program, so states have a share that they're responsible for. True to the bill's theme, the provider tax language treats expansion states differently from non-expansion states. So non-expansion states are required to freeze current rates, but for those expansion states, again, that's 40 states and DC, they are initially required to freeze rates, and then beginning in FY28, they must start winding down, start reducing the threshold by 0.5 percentage point until it gets to 3.5 in 2032. This is really heavy on the policy detail, but this is overall a big time reduction in the allowable provider taxes at the state level. This was a huge sticking point for a lot of different senators. You might remember Senator Tillis of North Carolina made this a really big deal, ultimately caused him to vote against the bill. We were hopeful that we would see this rolled back, but it was in the final bill, and it was the steeper Senate version of the provider taxes that passed. The big kind of takeaway from this is that we know this is going to blow big holes in state budgets and could force cuts to optional services. Despite its name, optional services include things like home and community-based services, which we know are critical for our community. Moving on to state-directed payments, or SDPs. SDPs allow states to provide additional funds to managed care organizations for specific services. Those services can include home and community-based services. We talked on earlier advocacy institutes about capping the SDP rate at Medicare rates, which would lead to lower reimbursement, and ultimately we're concerned it would lead to decreased access to care. So the language in the final bill that passed limits SDPs and again treats expansion states differently from non-expansion states. Non-expansion states must cap at 110% of the Medicare payment rate, and expansion rates must be equal to 100% of the Medicare payment rate. Moving to the Rural Health Transformation Program, you might hear this referred to as the Rural Hospital Fund. This gets back again to the provider taxes. A lot of senators, again like Senator Tillis, recognize that the provider tax changes would significantly impact health systems in their state, especially rural health systems that are already operating on shoestring budgets. So included in the final legislation that passed was $50 billion over 5 years. So it's $10 billion a year. And basically, states would submit applications to CMS to get this funding to help stave off the more significant impacts to providers. As you see on this graph here, I believe this is from KFF. This does not make up for the loss of funding on provider tax limits that were also included in the bill. So we also know that when these types of provider funds roll out, often providers have a hard time tapping that funding, so we'll be watching closely the implementation process for that. Moving to expanded home and community-based services, or HCBS. This is language that you might remember from 2024. This was originally standalone legislation called the HCBS Act. I forget what HCBS stands for. You might remember that this was almost included in the end of the year health package. At the end of 2024, it was removed before that bill ultimately passed. Essentially, this allows states to provide waivers for home and community-based services for individuals who don't meet an institutional level of care. The funding formula determines how much is allocated, but the intent is to help support additional waivers and expand access to home and community-based services. As many people on this call know, there are long wait lists for these services in the states. This is something that we would have a different conversation around if it was included in a different package or just was standalone legislation. But again, it's rolled up with these unprecedented cuts to the overall system. From MDA's perspective, we always will welcome additional funding for home and community-based services, but we know that this isn't going to stave off the cuts to those services that we'll see because of the other provisions in this legislation. Moving on to home equity limits. So most Medicaid enrollees who qualify for Medicaid due to a need for long-term care, they must meet certain limits related to home equity. So this year in 2025, the rules specify that a state's limit on home equity must be between $730,000 and $1,097,000. These are amounts that are updated each year for inflation. This new law reduces the maximum home equity limit to $1 million regardless of inflation, and that's effective 2028. We are concerned about this provision, that it will make it more difficult for the neuromuscular community to qualify for long-term care, especially if you have inherited sort of multi-generational family homes. So moving to the next slide. I know that was a lot, but I'm going to move on to eligibility restrictions and barriers to access. Starting with work requirements, this was a big piece of the final bill. If you have joined our earlier advocacy institutes, you've definitely heard about this. The final bill included new requirements on the expansion population. Specifically, this is for people aged 19 to 64 who are either applying or enrolled via expansion. Folks must demonstrate compliance that they're working at least 80 hours hours per month or 80 hours per month of community engagement or participation in a work program. There are additional ways to demonstrate compliance. You can show monthly income equal to minimum wage times 80 hours. You can show that you are enrolled in an educational program or a combination of different things. There was also a provision included around seasonal workers to make it easier for them to meet the requirements. And they also included some exemptions. And you see it here in quotation marks because we know that these exemptions often fail people. But they do have exemptions within the statutory language. It includes people who fall into the medically frail category, so people with serious health conditions, parents or caretakers of disabled individuals, parents of dependents under age 13, that's lower than what was in the House version, and people with disabilities. But we know, again, that people can and will be caught up in the administrative burden. They might not be screened properly. We also know that people in the neuromuscular community, they're going to feel the impacts to the care workforce. A lot of personal care assistants, a lot of that in-home care, they rely on Medicaid and Medicaid expansion for coverage. So this is a really big deal, something we were extremely concerned about. As for implementation, it's a little unclear. We will need rulemaking to kind of figure out the details of this, how they're going to identify who qualifies for an exemption, how they'll verify disability. All states do have lists of who is eligible for Medicaid due to SSI, Supplemental Security Income Status, who is dually eligible for Medicaid and Medicare. That might be how they identify people with exemptions, but we don't know because CMS has not started the rulemaking process, which will come in June of next year. So the bottom line here is states don't have perfect lists of who meet these exemption definitions. It does mirror some existing exemptions in law, such as related to SNAP, but there will be huge problems with states implementing this, especially on such a quick turnaround as given in the law. Again, one last thing on implementation here. Implementation was a bit of a tricky point for lawmakers. The language included in the final bill allows exemptions for state compliance no later than 12/31/2028. So if states are demonstrating a good faith effort to comply, they have a little bit more time, but otherwise states can and will start moving faster than that. Some already have waivers submitted to implement work requirements. Again, we're looking to see that interim final rulemaking in June of next year to more explicitly lay out what those requirements are going to look like. All right, next is rollback of the eligibility and enrollment rule, as well as the nursing home staffing rule. Language was included in the final bill that was meant to roll back the E&E rule. This did a few different things, and we're going to come back to this in the Medicare piece, but it streamlined the application process, the enrollment process in Medicaid, it aligned renewal policies for all Medicaid enrollees, and it facilitated coverage transitions between Medicaid, CHIP, and the ACA marketplace. It also rolled back really the heart of the nursing home staffing rule, which basically said there's a minimum number of nurses needed in nursing homes, at least one on site. It is a 10-year moratorium on implementation of that rule, but it's essentially a rollback. Last on this slide, administrative burdens. We also saw included in the final bill more frequent eligibility checks for the expansion population, a requirement for redeterminations to occur every 6 months. There was supposed to be an amendment to carve out people with disabilities from that requirement, but that was ultimately not offered in the end. So now I think we're going to switch gears to the ACA. So I'm going to turn it to Paul to talk about marketplace changes.
All right, thank you, Shannon. So as you can see, as you can hear, lots of changes to Medicaid as included within HR 1 or the One Big Beautiful Bill Act or the Reconciliation Bill. They're all the same thing, just referred to 3 different ways. So we did our best to cover Medicaid there, and we can always go back and answer any questions anyone has about what Shannon presented for sure. But now we want to just touch on changes in first the Affordable Care Act marketplaces, and then second in Medicare. So for the Affordable Care Act marketplaces, of course, these are the marketplaces that were created by the Affordable Care Act back in 2010 and actually went into effect in 2014. You can kind of see that in the graph on the right side of your screen. And these are private insurance plans that Both individuals can go and purchase themselves for health insurance for themselves if they're not offered health insurance elsewhere, whether that be through Medicare or Medicaid, or whether that be through one's employer. But one's employer can purchase health insurance for their organization, for the company, through the ACA marketplaces. So the changes to the ACA marketplaces are actually relevant to millions of people, because millions of people get their insurance through the Affordable Care Act marketplaces, either independently themselves or through their employer, generally speaking. So these changes are to how the marketplaces by and large run, not as much to the quality of the health insurance itself, but how one is going to be able to get that insurance in the first place. So one of the first things that I want to mention is that the bill effectively ended auto renewals for plans starting 2 years from now. So that might not sound that big of a deal, but for people who like their plan, they don't really want to have to go through a complex process to reevaluate if they want to get a different plan for the ensuing year. They can just be automatically re-enrolled into the following plan year within the same plan. That will no longer be allowed within the ACA marketplaces. Now this legislation would force people to have to go through the whole process of re-enrolling rather than being able to be auto re-enrolled instead. Previously, and I'm not going to get into the details of how the tax credits are calculated and paid for and so forth. Maybe some folks on the call tonight have experienced this. Maybe you want to get into the details, but it's not going to be me tonight. But in any case, there is a change within the legislation that pertains to actually recapturing some of the excess premium tax credits. When people had estimated the amount of income for the ensuing year, and then they got a tax credit that went to help pay for their health insurance. If they overestimated that, previously, if they were below a certain amount of income, the IRS wasn't going to come and smack down that individual who made a little bit more than they had anticipated making, and thus they got a little bit more of their premium tax credit than they should have. This legislation would actually result in the IRS trying to recapture that excess premium tax credit, and that's starting ASAP. That's starting essentially in next year. Previously, we might be familiar with enrollment periods in general. This is when you, depending on your insurance, could be October, could be November, could be December, but it's that time of year in which you re-enroll within whatever product it might be, in this case, health insurance. There are also things such as special enrollment periods, and this legislation got rid of some of the allowable special enrollment periods, particularly for those who are qualifying based upon low income. It got rid of low income special enrollment periods, meaning if your income dropped a certain amount, even if you didn't qualify for a different kind of special enrollment period, such as if you got married, you lost your job, you got a new job, you have a new child and you need to enroll them into health insurance. Those are all kinds of special enrollment periods. And by and large, those are continuing. It's the special enrollment periods that had to do with one's income dropping substantially enough to qualify for a low income special enrollment period. That is no longer allowed under the legislation. Something a bit complex in the interplay between the Medicaid provisions and the ACA provisions have to do with qualifying for the premium tax credits, the tax credits that help people pay for their premiums based upon their income. And one thing that this legislation does is, if you think back a few minutes to when Shannon was talking about the work requirements, the community engagement requirements that are now law that will be required of individuals starting about the beginning of 2027, if individuals are found to be ineligible for Medicaid because they violated the provision of the work requirement that was requiring them to be engaged within some kind of community engagement for 80 hours in a given month. If they violate that, if they lose their Medicaid because they worked 78 hours, or they didn't work at a qualifying job, or the letter got lost in the mail, those are all ways in which people can violate Medicaid work requirements. They would also then be ineligible for tax credits within the ACA insurance marketplace. So that's a bit of a 1-2 punch. That's if you're going to lose your Medicaid and you can't get help getting private insurance. And so that was something that was we were very unhappy about, but that now is law. So it goes to show even more important why it's going to be important for our community, any community, to try to comply with the work requirements that may be coming in a couple of years. The final thing I want to mention pertaining to the Affordable Care Act marketplace is actually something that was not necessarily included in the bill. It was something that was not included in the bill, and as a result, the uninsured rate is going to go up substantially. And that's the extension of the advanced premium tax credits. Now, the advanced premium tax credits were created in 2021 as part of the American Rescue Plan. This was, of course, the beginning-ish of COVID times. And what this legislation did was it actually plussed up the premium tax credits for certain people to make health insurance even more affordable than, or let's say even less unaffordable for some folks than it was previously. So that's why those are advanced premium tax credits compared to other premium tax credits. Now, these advanced premium tax credits expire at the end of this year. They expire at the end of 2025, meaning they would no longer exist starting next year. And actually, without these advanced premium tax credits, the nonpartisan Congressional Budget Office estimates that 6 million people won't be able to afford health insurance next year. So I want to just mention a few points on the graph on the right side of your screen here, because you can see this is the number of millions of individuals that are uninsured in the United States starting in 2000. And you can see in 2000 up until about 2013, there were anywhere from about 40 to 46, 47 million individuals or so who were without health insurance in the United States. When the ACA was finally implemented in 2014, it was signed into law in 2010, 2014, then the uninsured rates went down substantially. The number of uninsured people went down substantially. It went down into the 30s, starting at 36, and then actually sometimes it was in the high 20s. And that's even despite all of the economic hardship that COVID brought on. That was actually lowered even further, as at least in part because the advanced premium tax credits were created in 2021. That's where you see the number of millions of individuals in the United States without insurance go all the way down to about 25 million people. You can see the collective impacts of this bill as estimated by the nonpartisan Congressional Budget Office, that we would see upwards of 17 million individuals, more individuals being uninsured by 2034 than if this bill was not passed. That's that red bar that you see on, or orange, depending on how you see that. On the far right of the graph there, we go back up to about 44 million individuals without health insurance, which is very similar to the rate prior to the Affordable Care Act being implemented. So that's the gravity of what we're talking about here with the legislation in general, not just with the provisions pertaining to the ACA marketplace, but with all the provisions put together. So that is the quick summary on the Affordable Care Act provisions. I see some good questions coming into the chat and the Q&A. Thank you everybody for those. We're going to get to those in just a little bit in our Q&A portion. So I want to move on to the next slide and just spend a minute or two on Medicare. Because we've covered a good amount on Medicaid and some of the Affordable Care Act, and by far those are the health insurance types that are most affected by the One Big Beautiful Bill Act. But there are provisions that affect access in Medicare, and I'm going to name 4 of them in particular. So the first is that as part of the repeal of some of the rules that the Biden administration put into place in access to Medicaid and Medicare, there are implications for Medicare beneficiaries. One implication is within the repeal of this rule that I have screenshotted here pertaining to Medicaid in particular. It actually repeals the programs that are directed at the intersection of Medicaid and Medicare, people who are dual eligible, people who are receiving low-income subsidies under the Medicare program and thus also potentially qualify for Medicaid. What this provision of the bill does is it repeals the rule that made it easier for folks who were on Medicare but needed assistance to pay their premiums, needed assistance to pay the out-of-pocket expenses that those on Medicare sometimes have to pay, and made it easier for them to access Medicaid. So the repeal of that as part of this legislation means that it will no longer be as easy for individuals in the Medicare program to access low-income subsidies and Medicaid to help pay for their health insurance under Medicare. There also is a restriction on access to Medicare Part A for those who are in the immigrant population. Medicare Part A, for those of you who might not know, is the hospital part of Medicare. It pays for the inpatient services. And previously, individuals who were certainly of some immigrant classes could access Medicare Part A. That would no longer be allowed as part of the One Big Beautiful Bill Act. And then the two other things that are a little bit different than what we've been talking about thus far, because they don't pertain to access to health insurance quite as much, they're a little bit different. The first is a bill that was actually included in the One Big Beautiful Bill Act called the Orphan Cures Act. It kind of rode along with the legislation and thus was signed into law. And what the Orphan Cures Act does is it actually excludes all orphan drugs from the Medicare price negotiation program. So this was passed as part of the Inflation Reduction Act back in 2022. And this, as I'm sure many of you have heard in the news or are familiar with, is the program in which Medicare actually negotiates drug prices of certain therapies. Now, orphan drugs that only had one indication on, or actually one designation, were excluded. So those orphan drugs that only treat one population and just that population, they were excluded. They were not going to be negotiated. That was negotiated as part of the legislation in 2022. Now, as part of this legislation, all orphan drugs are excluded. So there could be a drug that treats 10 different common diseases and one rare disease. Previously, that may have, or several rare diseases, that may have been included within Medicare price negotiation. Now that would also be excluded. Any drug with any orphan indication or any orphan designation is excluded from Medicare price negotiation. Now, some people might say that's a good thing because there are concerns that by allowing for negotiation of drug prices, that can disincentivize development of therapies in the first place. Others may say that's not a good thing, that drug prices are high enough as they are. We think there should be negotiation. So either way, regardless of your viewpoint on it, at this point, orphan drugs will not be negotiated as part of the Medicare drug pricing program, drug price negotiation program. The final thing I want to mention is a little bit wonky, and it has to do with legislation passed about 15 years ago pertaining to sequestration. That might be a term that some of you remember from way back when, but it has to do with when the deficit grows to a certain amount. This legislation would actually force the administration to cut spending in specific areas. And that means if the deficit grows to a certain amount, one of those areas is Medicare. And this legislation will, at least according to the Nonpartisan Congressional Budget Office, grow the deficit pretty substantially, upwards of almost $4 trillion. And because of that, unless Congress acts, then the government, the administration, any administration would be forced to cut spending in certain areas to try to offset some of the growth of the deficit. And one of those is Medicare. And the Congressional Budget Office estimated that unless Congress steps in and prevents this from happening, there could be upwards of $500 billion cut from the Medicare program over the next 10 years. So we're talking about $50 billion a year. Now, I keep caveating this with unless Congress steps in, because Congress has stepped in other circumstances to prevent these kinds of cuts from happening, and they might do that again. But they also might not. And if that's the case, then we can expect each year the Congressional Budget, not the Congressional Budget Office, the Office of Management and Budget, OMB, to publish how they are going to cut these billions of dollars from the Medicare program in any given year. And we know, of course, many in the neuromuscular disease community rely on Medicare as their main health insurer. So if that actually is the case, if that does come to pass, that would be very concerning for those in the Medicare program. So with that, I think that concludes our tour of the policy updates in health insurance and access to healthcare. There are a couple more things we want to mention in other provisions in the legislation that affect our community, and I'm going to turn it back to Shannon for that.
Thank you, Paul. So a couple more provisions to get through that we haven't covered yet that still will impact the neuromuscular community. First, starting with the extension of ABLE provisions. Included in the final bill was the ENABLE Act, which you may have seen or read about. MDA is on record as a supporting organization for that bill. As background, ABLE accounts are tax advantage savings plans for people with disabilities. There are some stipulations about how and for what purposes they can be used, but 3 provisions were set to expire at the end of this year if Congress did not act. So now that they were included, they have been permanently extended. One is the Able to Work provision, which allows you to make additional contributions to your ABLE account. They also included the Savers Credit, which is an additional credit of $2,000, and then they also included the 529 to ABLE rollover, allowing you to roll over certain college savings into your ABLE account. So that is a good thing. That is a small silver lining that was included in this bill. Otherwise, it would have expired this year. Other changes that are not great are greater restrictions and huge cuts to SNAP, the Supplemental Nutrition Assistance Program. Huge changes to this. Billions have been cut from the program. Work requirements, which have always been a facet of SNAP, they have been expanded, and costs have been shifted in a massive way to states. It's estimated that over 22 million families will lose their SNAP benefits through these changes. Please reach out to me if you receive SNAP benefits. If you want to understand more about these changes, the Resource Center is also here to help with that. And now I think we want to pivot to talking about the future and the path forward for MDA advocacy. If you want to move to the next slide. So as we move into implementation, we will continue to advocate to protect access to services and care for the neuromuscular community. And as always, MDA's Resource Center is available to help with one-on-one benefits navigation. I know I saw a couple comments in the chat about how this may impact your own coverage. Please feel free to reach out to them. You can reach out to them by phone, by email. We're going to copy and paste the information into the chat so you have it there. We also have a webpage on the MDA.org website for how you can plug in with the Resource Center. That being said, we also know that the policy opportunities don't end just because this bill has passed. Further potential policy opportunities include amending the legislation further. So we know that a group of senators, a small group of senators, had issues with a lot of the Medicaid and ACA changes that we talked about tonight during the legislative process. Some even speaking out openly, like Senator Hawley, about amending the bill post-passage. So given their openness to amending it, we'll certainly be working with Congress on what we'd like to see from that process. We'll also work on delaying or stopping implementation altogether. So as we near some of those deadlines for implementation, we'll work with Congress to reconsider or delay some of the more dangerous provisions. We've seen them do that with big bills in the past. And we'll also work with states to ensure that Medicaid cuts don't fall on our community. We know that states are going to be forced with really difficult decisions as a result of the holes that have been blown in their budgets through this bill. So we'll be working hard to ensure that neuromuscular voices are uplifted during those difficult budget conversations, and the importance of preserving access to disability services. And then, as always, we will support additional policies that balance out the cuts in services. We'll continue to advocate for greater funding for long-term care, including home and community-based services, and just better access to care for the neuromuscular community overall. And with that, I'll turn it back to you, Paul.
Thanks, Shannon. Just one, I think, final slide before we can spend some time in the questions. And excellent questions everyone's putting in the Q&A as well as the chat. Keep them coming. There's some really good ones that I'm looking forward to covering there. I wanted to spend just a minute on other ways in which we're going to be working together, even just outside of the context of the One Big Beautiful Bill Act and what's still to come with the implementation and trying to mitigate the implementation of the effects of the One Big Beautiful Bill Act on access to healthcare and services, because there's also so much more that we can be doing literally right now, literally this evening. If anyone's watching and feeling a little frustrated by these changes in policy, there are ways to channel that right now that we would certainly encourage you to do in other areas that are ripe for conversation on Capitol Hill right now. And we're going to be looking, in addition to mitigating the effects of the legislation, for these other ways to be supporting the community. For example, right now we're still seeking to reauthorize the rare pediatric disease priority review voucher program up in Capitol Hill, and we believe there's a chance we could get that actually passed into law by the end of this year. And I actually saw a question in the Q&A. This is my opportunity to head over to the Q&A to answer a question. There was a question from Keith. Is there anything in the bill that sets the budget of the NIH, or does that happen in the appropriations bills? Anything in the bill that indicates the NIH budget will be cut? So there's nothing within the One Big Beautiful Bill Act that directly implicates the NIH budget. But I will say that the amount that the legislation is increasing the deficit could limit funding for literally everything else going forward. If the government is constrained with how much, in this case, it would be how much money is not coming in because of the extent of the tax cuts that were passed, that they won't be able to fund the NIH as much or the FDA as much, or choose whichever government program is important to you. They'll have less of an ability to fund those programs because there's going to be that less revenue coming into the federal government. But to answer your question, Keith, there's nothing specific about the NIH within the One Big Beautiful Bill Act. However, they literally this week are debating NIH appropriations. This is a decision, and they being Congress, this is a decision that Congress needs to make by the end of September. That's when the current government funding runs out. And so the appropriators this month in July, and we expect again in September, are expecting to be debating if they, to what extent they're going to be funding the NIH and the Food and Drug Administration and many of the other agencies that we care about. And so I'm going to make a plug right now for, if you're looking to take action in something, we have a live action alert right now that Mark is going to be posting here momentarily. Mark or Jory will be, that pertains to telling Congress, don't slash the budget of the NIH and the FDA. It's far too important to the future of new therapies for those with neuromuscular diseases to slash the budget, as is actually proposed within the administration's proposed budget. That Congress cannot go along with that. They need to robustly fund the NIH and the FDA. The other thing I'd like to mention is there are many other ways in which we are seeking to increase access to services for our community, one of which resides in access to education. And we also have an active action alert out there right now asking Congress to fully fund the Individuals with Disabilities Education Act, IDEA. This has been a problem for years, that access to accessible education through the IDEA has been underfunded by Congress, years if not decades. And this is something we're asking Congress to fix, to fully fund the IDEA. So that's another action that you can be taking this evening or tomorrow, whenever you would like to tell Congress to get the job done. The final thing that I want to mention that you can be doing is you can apply for MDA on the Hill. If you're listening to this and you're hearing, why are those folks up in Congress doing this and that? Well, by joining us in November 2nd through 4th, you'll have the opportunity to talk with staff and maybe even members themselves on whatever issues are going to be timely come November. We don't know specifically what those are as of yet. It's only a few months away, but we'd like to choose the issues that we know are on top of mind for those in Congress. Those are timely, those are topical. And so please do consider applying. We're going to add that link as well out there so that you can apply to join us in November. We wish we could say yes to everybody. That's why we're saying apply, but sadly we can't say yes to everybody. It's a popular event, but please do follow that link, apply today so you can hopefully join us come November. So obviously, just to kind of sum up with the general theme of much of what we're saying before we start with questions, disappointing for sure that this legislation passed about 2 weeks ago. We all worked very hard to try to prevent the legislation from passing. And as Shannon mentioned, some of the most egregious, most harmful, most cut to the core of the Medicaid program in particular provisions were not included. And that was because of the advocacy of all of you and the advocacy of everybody in our community trying to prevent those worst, absolute, horrific provisions from being included. And yet we're still looking at a bill that could result in 17 million people losing their health insurance, or fewer people having health insurance by 2034. So it's disappointing. But as Mark started with, it's not because of that we didn't do our very best. Obviously we did, with everybody across the organizations and across our entire community, reaching out to Congress, telling them to preserve Medicaid and preserve access to coverage and services as best as you could. And it's that energy that we need to keep up. It's that energy that we need to channel into these efforts that I just mentioned, as well as the efforts that will try to mitigate the impacts of these potential cuts over the next several years and beyond. So with that, I think we can head into our question and answers. We have 10 minutes left in our hour. That's a good amount of time. So why don't we start in the Q&A box? That's where I'm going to start and see if we can get to some of our questions there. Then I'll move to our chat box from there. So Shannon, I have a question. I'm going to start with you. And this question comes in from Nancy. And Nancy is asking about the role of CMS, and CMS stands for the Center for Medicare and Medicaid Services. And this is a really good question because, Shannon, you mentioned a handful of times that it's going to be really impactful, the choices that states are going to have to make over the course of the next 5 to 10 years as a result of their budgets being severely constrained by that much less federal funding being able to go to states to fund their Medicaid programs. But where does the Center for Medicare and Medicaid Services at the federal level fall into all of this, particularly on the Medicaid side of things? What would you say about CMS?
Yeah, that is a really great question. And with a lot of the different provisions, at least related to Medicaid, a lot of the devil is going to be in the details, and a lot of the details are being held until rulemaking. So just taking work requirements as an example, before states can determine how work requirements are going to look for their specific state Medicaid program, CMS has to first put out interim rulemaking and put out essentially guidance to states on how they need to structure their requirements, how they need to go about identifying who qualifies as a person with a disability, who qualifies for the other exemptions. I imagine that process will be a multi-step process. There will be opportunities for advocacy organizations to kind of inform the process, state organizations that work with Medicaid programs to inform the process. A lot of us will be watching CMS very closely as they are required by language in the bill to put out guidance, to put out rulemaking, to help states implement these massive changes to their program. So it will be a big role, but we also know that we have a new CMS leadership in place. We have a new administration. So it's really unclear how they're going to approach these massive, massive changes. And I think that's where those additional policy opportunities, when you talk about delaying implementation, and we talked a little bit as we were going provision by provision, that states will need time to do what the bill is requiring of them. So there's going to be a huge role for agencies in kind of figuring out how this works in practice for people, which is probably not a very fulfilling answer. I can speak personally. I know that a lot seems unclear in terms of how this is going to look and feel in your own state, but we are closely watching for CMS action and other agency action on a number of these provisions.
Well said, Shannon. Thank you. So before I turn to Shelley's excellent question within the Q&A, I want to answer Terry's. Terry asked, were there other policies related to orphan drugs besides the price negotiation policy mentioned? To my knowledge, there weren't any other policies that were specific to orphan drugs, but I should mention that one of the concerns that we have with the Medicaid provisions are that with state budgets being so constrained, due to the cuts in federal funding to state Medicaid programs, that states are going to be finding new and creative ways to delay access to orphan drugs in their Medicaid programs. We've already seen this in some cases with some of the new therapies that have been approved, that states are finding ways to kind of put up barriers to delay access to expensive orphan therapies that have been approved. And if these are tactics being used now by states, we can only envision how these tactics are going to be used later on. But that's, again, one of those kind of indirect effects of this legislation on orphan drugs in particular, rather than perhaps a direct effect, but one that we are still envisioning could be the case. So back to Shelley's question, and Shannon, I'm going to turn back to you for this one. And she references that in her state in 2024, reimbursement rates were increased substantially for Medicaid waiver home healthcare aides, which is excellent, and that made a tremendous difference in being able to recruit and retain caregivers. So is this something that you could see being affected by the changes in the One Big Beautiful Bill Act, the way in which states are able to reimburse or pay for home health care aides?
Yes. I think, states, it depends on the state that you're in. States may use those provider taxes that we talked about to help kind of shore up certain optional services like home and community-based services that may be what you're seeing in Ohio. At the end of the day, what this bill is taking out, so Medicaid is the biggest source of federal funding for states. What this bill is taking out of state Medicaid programs will be very difficult for states to supplant. Even for those states that have been able to beef up and shore up home and community-based services, especially those states that have had incredibly long wait lists and huge issues with people dying waiting to get off of these wait lists for services. It may help mitigate impact, but we know that this will devastate the optional services budget for states. There's just no way around it. I don't know if that ultimately answered the question, but let me know, Shelley.
That's how I would have said it too, Shannon. The states are going to be looking for every way to constrain costs in their Medicaid program, and that will likely include the rates that they pay providers, not only home health care aides, but physicians, physical therapists, nurses, anybody. And that's why one of the reasons for why you saw hospitals so concerned with these changes in the legislation, because they envision being paid dramatically less by their state Medicaid programs and thus potentially having to close. So home health care aides are not exempt from that dynamic, unfortunately. So that is something that we certainly are concerned with. And that kind of gets to a question that Liz asked in the chat box. Will Medicaid cuts impact the administrative paperwork on providers for existing services on top of what they already contend with, including, say, prescription PAs, PTOT, speech order specialist referrals, etc. Now, as for the administrative paperwork on the clinicians, the providers themselves, that's not something I am immediately familiar with in the context of the legislation. I don't know if there were provisions. There were some that were going to, I believe, be more intentional in ensuring compliance with state law and state Medicaid programs pertaining to the providers being eligible to participate within the Medicaid program. Shannon, I don't know if that's something you might remember off the top of your head. That might be a question for Joel Kartner, who many of you know that unfortunately Joel was unable to join us tonight.
It's nothing touching prior auth or step therapy, that kind of utilization management burden on providers there. There was at one point included some PBM, some moderate pharmacy benefit manager reform that may have in a roundabout way helped with provider burden, but that was ultimately taken out of the final bill. I don't think anything touches that sort of provider burden.
Yeah, I think you're probably right there, Shannon. But as I mentioned before, we could envision if these cuts are allowed to be implemented and states are feeling squeezed, it might not be the administrative burden that are placed on the very clinicians and medical providers, Liz, that you mentioned, but it will be that they're going to be paid potentially a good amount less because states' budgets just won't be substantial enough to be able to pay them as much as they have been. Or certainly that they wouldn't be able to increase payments if those are the cases. A couple more questions I want to see if I can get to in the Q&A box before we wrap up. I see we're just 2 minutes away from our hour, and I want to be sure I can bid everyone a happy evening here just in a few minutes. There was a good question about the orphan drug provision that I mentioned, and as I apologize I didn't clarify this as I was presenting. Orphan drugs are drugs for rare diseases. This is a term that comes from the Orphan Drug Act of 1983. So a drug for a rare disease is called an orphan drug. That's just how it's been called in statute. But there was a question from Stephanie on explaining the coverage within Medicare further. Is this bill, if this bill excludes negotiations for medications, can Medicare simply decide not to cover the medication? Now the answer by and large is yes, that Medicare has within their ability, with some exceptions, including protected classes, which we can't get into tonight, but with some exceptions, they can exclude certain therapies from the Medicare program. What Medicare does is they release national coverage determinations, and this isn't just true for prescription drugs, this is true for a number of different services that are provided under Medicare, that they can say, we, Medicare, are not going to pay for that. Now, that's possible. That could happen in the case if an orphan drug is not to be negotiated. But by and large, we have not seen this happen at with the Medicare program. By and large, Medicare is pretty good at covering all therapies, but that includes rare disease therapies. So we don't know if Medicare would be more likely to not cover an orphan drug because it's not being negotiated. It's possible. Can't promise that that's not the case, but that's not something that we're necessarily envisioning happening, at least certainly not in the short term, that the Medicare program wouldn't cover an orphan drug because it's not being negotiated. All right, let me see if we can just answer one more question here, because that's going to be hard to choose because there's a number of good ones. Let's finish with this one. This is from Samuka, and actually I'm going to do a bit of a two-parter here because Samuka asked two questions that are relevant to each other. Can you talk about more specific ways where MDA can stop the implementation or advise in amending the legislation? How can you still advocate effectively to reverse the damage of this legislation? And then you follow that up with, are there ways in which we're going to be supporting state level advocacy to address this? So just more details on how we're addressing all of this. My short answer to you, Samuka, is there's more to come. I think the bill has been in law for 8 days now. So we're doing a lot of assessing on what we can be doing in this next phase of advocacy on these proposed cuts. What I can tell you is we're certainly going to be working at the federal level. That's where we specialize. That's where we're strongest. We're going to be working with legislators in both parties, as Shannon said, to every opportunity we can roll back some of these cuts. And we have a whole lot of allies in doing so, not only within the patient community, but in the provider community, in the public health community, in the disability community, many different areas. And so there's going to be a lot of momentum to preventing some of these most harmful cuts from happening, especially since we have a couple of years, in some cases, until they're actually implemented. So I can tell you that there's going to be a lot of efforts at the federal level. We're going to keep you all up to date on that as best as we can as we go along. At the state level, as I mentioned, we're very federally focused by and large within our public policy making and our public policy work in Washington, D.C. But given the effects of the legislation and how damaging they could be to our community, we could be considering getting more involved in state level advocacy. Not going to say that that's definitively going to happen, but we're going to be looking to support our community any way that we can, and that could include some state level advocacy down the road. But for now, as I mentioned, it's been 8 days, I believe, maybe 10, 8 or 9, 10 days since the legislation has been signed. So we're doing a lot of assessing and planning and thinking about what's going to come next. And trust me, we'll do many more updates for the community, including potentially within advocacy institutes, as that all crystallizes a bit further. So with that, unfortunately, I think we do have to close. I know there are several more questions. Keith, I'm sorry I couldn't get to some of your questions. Omar as well. Please do email us at advocacy@mdausa.org if you want to continue the conversation on your specific questions. That's advocacy@mdausa.org. Happy to continue the conversation there. But just being respectful to everyone's time, thank you again for joining us this evening. Thank you again for your participation within our efforts over the last several months, and the efforts only continue from here. So please continue joining us, and with that, I wish everybody a very happy rest of your evening. Thank you.